Yes, sir.
Jack, you don't need
The coat? Good. Yeah, that's probably true. It's good.
That's awesome. There's that one. He's amazing. He's amazing.
Hi.
I'm touting you.
Oh, thank you. That's kind.
There you go. Yeah. Absolutely.
She's here.
Oh, she is?
Yes. Okay. Emma, she just walked in. Oh.
Hi, sweetheart. How are you?
Dr. West.
Hi.
I'm Brian Cook. I've been emailing. I'm with the
Oh, great.
artist.
Great.
Nice
Okay.
to meet
Yeah,
you.
thanks.
I thought I saw you at SWAG, but I knew I was going to see you here, and I didn't want to bother you.
It's all good. I was in and out of SWAG anyway,
Yeah,
so.
and I follow you on Twitter.
I think I know you.
Yeah. No.
On the,
No, I just follow you on Twitter. We haven't
okay.
met before.
Oh, no. I just think I might have intermittently seen some of your tweets or something like that, perhaps.
I don't really,
No? Okay, then it's not you.
Yeah, it's not me. I'm more of a taker on tweet.
I got it. That's fine.
And I'm
It's all
like,
good.
wait, he was in San Francisco, now he's in Chicago, and now he's going to be in San Carlos.
That's all true.
He doesn't know when the heck he's going to be next.
No, I
Hopefully
do,
you're
but
on bed.
that's true too. I'm going to be scooting out pretty much as it ends so that I can make my flight. So.
What time's the flight?
Oh, no, I have a 9:30. I'm trying to actually make the 8:30 standby if I can.
Oh, okay.
I think that may or may not happen, but I'll be sleeping in my own bed tonight. So, and I've taken
Alaska Air.
Yeah.
I fly a lot of Southwest, and I don't know if you saw what happened today.
I did. That there was someone that sucked out. Yeah.
Yeah. Holy.
Well, I mean,
Pardon me for interrupting. We do not have a clicker for you, so
I do if you want.
Do you have? We
if
can
it
try
could go into a USB.
I'm not sure if it will work from way back where you are. Sorry, this has got.
Oh, that's fine. If it's far, that's
Yeah.
probably true. Okay. You want me just to say next?
You can just say next.
That's fine. I can do that.
And
Doesn't
Rocky is the man who's running your slideshow, so you're Rocky, next slide. Or if you work in your conversation, and on the next slide.
That's fine. I'll see if I can do that. So, yeah, I'm a
Oh yeah, please do.
kind of thoughts on my sleeve person.
Yeah, no,
so
I
don't-
appreciate. No, I.
It's not personal anyway. I just think.
Dr. West, I don't think it's personal.
Nah. I don't mean it personally.
No. But so I'm new to the position.
Okay.
New to the brand team. My boss has been in his position for about a year. We would just like to maybe meet with you, see if there is something that we can maybe
We're moving.
work
We
with,
got a lot going on. Good.
work with you on at some point.
Sure.
And so if I
Oh, it's easy to take this. It's your summer. Oh, good.
Logistic
Good evening, everyone. Welcome to the living room. Thank you for coming, everyone in the room and everyone online who might be joining us. Welcome, welcome, welcome. There are some new people in the room tonight. Hopefully there's lots of new people online as well. We're very happy to have you. My name is Danielle Hicks, and my role here at the Foundation is to oversee all of our patient programs and services. So anything that has a patient touch is my area of responsibility, of course, with an amazing team of people working with me to ensure that this program, as well as many others, go off without a hitch and are very successful. So we're very happy to have you here tonight. We're very happy to have Dr. Jack West here from Swedish Medical Center up in Seattle. Hi. Jack is a longtime friend of the Foundation, an amazing medical oncologist, and he's going to talk about some really new and exciting things that are literally hot off the presses and what it might mean for you. We're going to start like we normally do with our Around the Room. It's absolutely not mandatory. For those of you who are new, you do not have to introduce yourself, but we welcome it. Everybody likes to hear about everybody else and who they are and where they are in their journey. Some of us earlier on, other of us several years out. So I typically will pick on somebody because normally when I ask for a volunteer, nobody raises their hand.
Right.
Right?
Yeah.
Well, why don't I start with you then?
Okay.
Okay.
All right. I'm Bonnie, 13-year lung cancer survivor. So for anybody that's looking for hope tonight, sitting right here. Also the founder of the foundation and our second foundation, Alchemy, which is a research consortium. I see some new faces, and I'm going to come and talk to you somewhere along the evening. And welcome everybody online and in the room. Thank you to our amazing staff. And I'm so excited for you to meet Dr. Jack West tonight. Are there any people that are familiar with Grace? Okay, well,
Grace.
that's this man right over here. So it's an amazing program, and we're happy to be collaborating with him and working together.
We're going to talk a little bit about Cancer Grace after we get through sort of the education portion tonight, but I think you guys will find it really exciting. So I saw a couple of hands raised when you asked if anybody had heard of it. So by the end of the night, you will have all heard of it, and hopefully all be signing in and using it. So we're going to go to the right.
My name's Ron Berridge, and I'm the husband of a lung cancer survivor right here.
All right.
Is that all you have to say?
That's all I have to say.
Well, how about I love her very much? Okay.
I'm the lung cancer survivor. I was diagnosed in September 2016 after a year of a misdiagnosed cough. So I was diagnosed with adenocarcinoma, EGFR, and Ron isn't here yet, but he's always asking what the next subset is, and I've never known. I learned in my last appointment that I'm exon 19 deletion, okay, which is some kind of real normal garden variety of EGFR. I understand. Very difficult for immunotherapy to find. I'm understanding. Anyway, so that was for Ron, but he's not here yet. I've been on Tarceva for 18, almost 19 months with side effects that are manageable, except right now I have a bunch of scabs in my head that the dermatologists can't really figure out how to get rid of. What else?
Calamine lotion.
Have you asked Dave?
Calamine lotion. Dave.
No, it won't. They're so thick and embedded. They won't.
Friend.
They need to fall off somehow, and that hasn't been. I'm seeing 2 dermatologists. They'll figure it out eventually. I did have a scan early April. Everything looks great.
Good.
In fact, the appointment that I had most recently was with my UCSF oncologist, Dr. Blakely, and I was very excited to learn that he's going to be our speaker in June. And he's going to be talking about the targeted therapies and et cetera. So I won't go through. He caught me all up to date on that. It was wonderful, but I'll let you all wait till June to get caught up on all of that. I have joined the EGFR resistance group that
Yay.
Colleen started.
Yeah.
I haven't seen Colleen here since, but anyway.
They're up in Sacramento,
They're-
so
yeah.
she
Oh,
comes
they're in
down.
Sacramento.
Yeah, yeah,
Okay,
yeah,
I did that.
yeah.
I did letters to my senators and representative about HR
Woohoo!
4897.
Nice.
And told my story a little bit about
Okay.
why we need to make this research keep going on. And next week, I'm becoming part of a Natera blood biopsy trial for lung cancer progression.
Yeah.
And I think that's enough from me.
That's
Thanks,
giving
Joanne.
Dr. West some fodder to talk about.
I'm Marilyn. I'm a caregiver. My husband was diagnosed 13 months ago with stage 3 lung cancer. He's watching this from home. He was a little tired today, so
Okay.
he's attended, and we've watched it also on television, on the computer prior to tonight. So my first time.
Great.
That's awesome.
Thanks for
welcome,
coming.
welcome, welcome, welcome.
Oh, they have their own. Oh, well.
I'm Ina. I'm a 3-year survivor. I was lucky in that I had a difficult diagnosis, but when we finally figured that whatever was in my lung needed to come out, I was able to have it surgically removed, and I have a lobe and a half missing. But with a lot of help from my support here, my husband Steve, I've been back to doing pretty much anything and everything I did, and even some things I never did before. I challenged myself to do. So I'm feeling very lucky and grateful, and just happy to be here.
Danny.
And I'm Sid Steve, and in 7 days it will be 52 years since I married this young lady. She was 6 at the time, and yeah, I'm a caregiver, and it's a privilege to be here with everybody. Thank you.
Hi, I'm Sally. I put myself into a early detection study, the ILCAP, and 5 years later, one of the nodules grew, and I had stage 1A lung cancer. I had my lower right lobe removed, and I have other nodules. They just watch them, and nothing's grown significantly, and it's 9 years.
Awesome.
My name is Tina, and I was diagnosed in November of 2010. I tested positive for the EGFR mutation. I started taking Tarceva, and then after I saw 2 other doctors, they decided to go ahead with standard care treatment and do chemo and radiation. So I did that, and then after a clean scan, went back on Tarceva, kind of more like maintenance, because they knew that it worked for me because I had taken it previous to treatment. So, and that was 7.5 years ago. So here I am, still taking Tarceva.
Thanks, Tina. Tina, I sent you an email today. Did you see it?
No.
Check your inbox.
I will.
So we have a patient online, and I'm hoping that they'll say hello, who's in a similar situation, different drug, but been on it for a long time and sort of facing that. Do I stay on it because I'm NED? Do I go off? So I told her I would connect her with you so you guys could kind of hash out
Okay,
the
sure.
pros and cons of it.
Sure.
So,
Be happy to.
thanks.
I'm Rick, and I'm Tina's caregiver, who she doesn't need any care. In fact, she probably takes care of me more than I take
I think
care
so
of her.
too. Yeah, I think that's the case.
Thanks, Rick.
My name's Dave, and Joanne, I have information too. I was given this right away a year ago now, which is when I was diagnosed, was March of last year.
God, I can't believe
But
that.
I am adenocarcinoma, of course, and EGFR, but I have exon 19 mutation. So we're in the same boat. But I have more numbers and letters. E746 underscore A750 deletion. I'm not. High PDL1 expression by Keytruda assay. Assay?
Yeah.
This new language is not easy.
You're doing well.
All right. And so that's my story.
Okay.
And I'm sticking with it for now.
All right.
But anyway, I was
Okay.
diagnosed, like I say, about a year ago, and have been on Keytruda, have been on Tarceva for the entire time. and had 6 lesions in my brain, which they did SRS on, and over 5 days right in the beginning. And then that was back about April 1st, roughly. And then in October, there was a little swelling, I think, from one of those treatments that caused me to have a focal seizure. So I lost my speech for about 5 minutes. Everything else about me was fine. I could jump up and down, but I just couldn't speak. And then my brain rewired itself, and within a few minutes, I was talking again, little by little, word by word, sentence by sentence. Took, maybe 30 minutes to come back fully. Then they put me on a drug to keep seizures from happening. And so I've been on that, along with the Tarceva, and dealing with the side effects that, of course, we have, which are minor, thankfully. And no other seizures since. So things are good.
And I think, just want to point out, just for some new people in the room, that Dave found out about us, or his wife did, at a dog park. So it's one of those things where you never know who you're talking to. She happened to be speaking to, it turns out it was my sister-in-law who does all the finances here. And she was like, oh, you have to come down to the foundation. So talk about it if you feel comfortable with it, because you never know who you might be helping.
Yeah, and he showed up. He showed up pretty much right from the dog park and entertained everybody that night in a big way with an absolutely great can-do, I'm going to take care of this
I was diagnosed on a Tuesday at 5:30 at night, and I think I was here on Friday morning with Michelle.
Yeah.
And then I was in the living room, the following week.
Yeah, exactly.
Because I was the new kid on the block till he came.
Yeah.
You remember that.
Yeah.
Hi, Fred.
Hello. I'm Fred Palmer. I was diagnosed with non-small cell lung cancer in October of 2013, and I'm currently on immunotherapy.
Hi, I'm Betty Corner, and in September 2014, I was diagnosed with adenocarcinoma, and they thought I was stage 1A and ready for surgery, and they found brain mets, and that was kind of crazy. I'm a non-smoker, and I was totally shocked by the whole business. I was lucky enough to find this place, and I learned a lot about oligometastasis by coming to these meetings. And I did some CyberKnife for my brain mets and did well enough on Tarceva, exon 21, that they were able to operate on my right lower lobe, as in take it out, and look around while they were in there, and didn't find any nodes or anything. And I have been on Tarceva since, and I had a little scare with one of my brain mets growing, and it was found, they actually went in there to look at it, but it was found to be a necrosis. And that was about a year ago. But since then, I've had great scans, and I'm grateful to be here tonight.
Thanks,
Yay.
Thank you. In the back, yeah.
Hi, my name is Wayne. I'm caretaker for my wife, Rebecca, here. She was diagnosed with non-small cell adenocarcinoma in November of last year. We finished our first round of chemotherapy in mid-February. We had a scan a couple of weeks afterward, but it's too early to tell. There's a lot of stuff lighting up, but they found some small spots, which could be anything or nothing. So we're now under the same care as Tina's doctor, Dr. Neal, over in Stanford, and they started her on durvalumab for a couple of months, and we're anxiously waiting to see what shows up in our next scan.
Thanks, Wayne. Anyone down here?
Hi, I'm Kira Norton. I was diagnosed with adenocarcinoma, right? Sorry, it's kind of tricky. In February, I'm 22 years old, and
Hi, I'm Jack Norton, Kira's father. We found out about this place today, and here we are. It's been been a pretty rough road, and we're still going through it. So, fortunately, Kira has started this other medication, is alectinib, and I mean, she's amazing from what you would see her 2 weeks ago to today. Just 2 weeks ago, she can walk. She was bedridden and on a 24-hour oxygen. So she's just an amazing improvement. And then our nephew, he came out also to help us out with some caregiving, and really appreciate all the support. And there's been just some fascinating and you know, kind of miracle moments when you unexpect some things, and just humanity comes out and touches us, and we've been blessed. Thank you.
So, Jack, I'm Danielle. I'm the one that replied to your email today, and Bonnie's going to come up and give you a hug.
Yeah.
There is so much support to be had here, and so many connections we can make. You guys are very, very new to this space, but we work with a group of young people who have lung cancer, and I think when you're ready, if you're ready, being able to connect you with some of them who are like you, right? Same age, same sort of space in life, it will really be helpful by the way of support. So you'd absolutely came to the right place. And Bonnie's a really good hugger. Anyone else want to say hello? Are we good? Michelle, anybody online?
There's a lot of people, but Tina,
Jane?
she's reaching out.
Yeah. Okay. So Jane got the email. Did she get it? Okay. All right. So with that, what I've decided to do as of late, some of you may know, and I hope some of you were able to tune in. We just got back. I don't know when we got back. Tuesday night. Last Tuesday, a week ago. So Michelle and I were on the road, and we were doing some of what we were calling remote living rooms, but now we're just calling them sort of on the road living rooms, because they're not remote to the people who we are providing the living rooms for, just to us. But we were in Columbus, Ohio. We were in Nashville. We met a young guy who just celebrated his 30th birthday the day before we met with him. He's a stage 4 lung cancer survivor, ALK positive, I think. Who's looking to do some pretty exciting things in the Nashville area. Is what? Yeah, and Tim, we met Tim in Ohio. Tim and his wife drove to Columbus, Ohio from Cincinnati, and I can't remember how far that is, but
2 hours.
A couple hours, okay. So they drove out to be part of that living room, and then we had our living room in Memphis. So hopefully some of you guys got to tune in, and we're here this week, and you'll hear all about where we're going to be in a week and a half, and then the week after that. But what I've decided to do is, rather than me try to read from a piece of paper someone's bio, let them introduce themselves, say who they are, and why they chose lung cancer. So with that, and before we get into the education part, I'm going to turn it over to Dr. West to introduce himself.
Thank you. Hi, I'm Jack West, real name Howard, just lazy witness relocation. And no, but so anyway, we are the same person, Howard and Jack, and I grew up in Cleveland, Ohio, and between that and working in lung cancer, it keeps things real, and so I really like to have it be casual. I'm going to only be talking for 20-25 minutes or so, I think, and I'd like to have a lot of time for interaction, and so it'll be one of those ask me anything. I trained on the East Coast and then moved, well, actually, because I'd grown up in Cleveland and then was up in Boston for my training, I was driving to work in January and sliding all over the road thinking it would be really nice to not risk my life going to work every day. And I decided I'd really like to be on the West Coast and came out to Seattle and trained at Fred Hutch for my fellowship specialty training in medical oncology, and have been up there now for 20 years. And though there's a gravitational pull to California, I'm still pretty happy with it. Rains in Seattle, but I'm never going to complain about the weather, having come from where I have. So Anyway, I practice now at Swedish Cancer Institute, which is a large private center, a very big tertiary and quaternary care referral center, a lot of good lung cancer treatment, and it's great that I'm part of a solid team that works very closely together there. I had I focused in lung cancer in my fellowship training because I really wanted to work on a common cancer where there was such a need. And I'll just say as a historical context that it's astonishing how far things have gone. I know in the thick of it, there's daily challenges, but it's so different from when I started in it. People would ask, why did you choose lung cancer? Like, what's wrong with you? It was a hard field, and when I was in my fellowship, the question that was being asked in like the major journals and conferences was, is it actually doing anything to treat metastatic lung cancer? Are we moving the needle by giving chemo? And it was just becoming established that giving chemotherapy did help people live longer, but it was not so dramatic that you wouldn't ask the question. And amazingly, gratifyingly, over the last 2 decades, it has changed incredibly so that now lung cancer is a field that is among the most dynamic in all of cancer care. And I have friends from medical school who are not oncologists who say they resent that the New England Journal's just full of cancer developments all the time. And my colleagues in other cancers are kind of jealous of everything that's happening in lung cancer. It's dizzying. It's like the found money dream, how quickly things are happening in the field. And it's hard to keep up. And I think that's one of the themes that I would say about it's helpful to connect with somebody who eats, sleeps, lives, and breathes lung cancer, just because there have been a lot of developments in many other cancers. You just can't keep up with everything. And but with that, there's a lot of new developments all the time. Literally, the field has been changing even based on presentations done yesterday. It's no exaggeration. And there was a big press release of some work last week that I was thinking about doing a video on. I do some videos at home and put them out for people. And I thought, well, there's no point in doing that, because even if I turn it around in 48 or 72 hours, I knew there was going to be big news yesterday. It would only have a shelf life of 2 or 3 days before it was obviated. So it's a good problem to have. So anyway, I am married happily with 3 of my own kids, 3 from my wife's prior marriage. So it's like the Brady Bunch, but they don't get along that well.
That's like our family.
And I have a very, very great Keyshawn dog that I love, and those are the highlights.
That's great. So a couple things I want to point on that you said, Jack, before we move in, is one of the things is how fast things are happening, because you've been in this space clearly way longer than I have. I've been in it since 2003 when you were diagnosed, and I've surrounded myself with everything. But you said something very important. It is changing so quickly, which is why we try to drive home in this meeting and throughout everything we do, why it's so important to see a physician who has the knowledge and the what's the word I'm looking for? Most patients are seen in the community setting, right? And those of you who have been here and been coming to this meeting for years, some of you know that this is me beating the dead horse, but community physicians don't have the luxury of being able to specialize in any 1, 2, 3, 4, some.
Actually, just to clarify, I work in a community setting. It is fair to say most community-based docs are not super specialized.
Correct.
But, in truth, I would just say that it's very helpful to see somebody who is really focused on thoracic oncology.
Correct.
At least sometimes. And that's not to say you don't actually have to get the treatment by that person all the time. The Keytruda in whatever community is the same Keytruda at the specialty center. The antibiotics are the same. So you don't have to do everything. You don't have to get every infusion at a 90-minute drive away.
And to Dr. West's point, you know, he literally is just coming in from AACR, which is a big cancer program happening right now in Chicago. So talk about, you know,
so that was
as it happens.
Yeah, and that was gonna go ahead.
But I just wanted to say one more thing, that, you know, it's not about the name on the building.
Right.
It's about the physician within the building. So, you know, we help patients all the time find the best possible, you know, care within their home and their community. So, you know, some people think, oh my gosh, I have to be at such and such or such and such or such and such. And, you know, that's becoming, you know, a better opportunity for patients. So,
I would really underscore that there is not one best doctor or best place for everyone. There are some great people in all sorts of places, and there's some amazingly intelligent, highly respected docs who are not at one of the biggest 5 cancer centers, and that's okay. And I would say also that you can't be the exact perfect doc for every patient, because there's 2 parts of that interaction, and different people want or need different things. So I would just say that that there's some. It's not as simple as, you know, everyone needs to go to this or that institution. No. There's some great people, and frankly, at some of the other institutions, some of the best known ones, there's still some people who maybe just may not have as much experience and wouldn't be as, you know, you're seeing only because you came to that institution.
Right. Agreed. And there are definitely larger community cancer centers around the country, and, you know, some of which we've identified through our Center of Excellence program, those yet to be identified, that do have the ability. You know, but if you do happen to live in an area, several of which I have visited recently, where there's maybe not that option, to Dr. West's point, or to your point, I can't remember who said it, there is always the option for a second opinion somewhere and then go back and be treated at home. And the second thing I wanted to talk about when it comes to Dr. West and his commitment to lung cancer, and you touched on a piece of it, is in the last, you know, less than a week, he's gone from Seattle down here to San Francisco for what's called SWOG, the Southwest Oncology Group, which is a cooperative group that meets here in San Francisco, then back home to have dinner with his wife, and he flew to Chicago for the American Association of Cancer Research meeting, which is where some of this information that we're going to touch on a little bit tonight came out of, then flew back home to have dinner again with his wife, woke up this morning, went to clinic, and then flew back down here to be able to be here for you guys. So that's his level of commitment to this disease, and it's really admirable, and we are very, very grateful to have you here. So with that, let's get started on the topic.
So I'm going to stand for this so I can refer a bit to the slides, but they are not that detailed, and it's not going to be too much. And so I'm going to be talking as a very general introduction to the concept of immunotherapy and kind of where it's been historically, which is not ancient history. It's really just in the last few years where it is today, and I should qualify that by literally today, not tomorrow or next week, because that could be different, and the future, where we're going. And this is, I think you're hearing the theme, a very rapidly evolving space. We are still babes in the woods learning about this. And so, but I think that one of the key themes is this has been a big field, a big advance. It's not going to be the answer for everybody, but it has been a fundamental change and a big, important tool for many people, if not everybody. Okay, next slide. So I'm not going to go into much detail about how the immunotherapy works. The immune system is very complex, but what is worth knowing is that, like a lot of complex systems in the body, there is a balance where you don't want too much and you don't want too little. Just like clotting and bleeding. I mean, you don't want to get a blood clot because your blood tends to clot too easily when you sit down in the car for 2 hours, but you don't want to be bleeding all the time for no good reason. And there are many factors that help control that balance. And the immune system is the same. Your immune system is designed to identify foreign threats and attack them when you have an infection, or cancer has some role in that, because people who have significant immune suppression after, say, an organ transplant or a bone marrow transplant have higher risks of developing certain cancers. So the immune system does have a surveillance role trying to identify various foreign things that include cancer, but we don't want it to be so overbearing that it's attacking bystander cells in your body. And that's what autoimmune diseases are. And there are many, everything from rheumatoid arthritis to ulcerative colitis, vitiligo, various thyroid diseases, lots of diseases in the whole world of illness are caused by the immune system getting confused and attacking your own body cells as an innocent bystander. And so the treatments that we have are largely focused, the ones we're going to talk about today are mostly at the bottom right of this, and this is what happens at the tumor level. There's a tumor cell, which is the little blue, and then there's T cells, which are the muscle. They're the police force out there, and they interact by recognizing proteins on the cancer cell, which is the little blue dot called a peptide. That's just a recognized little bit. And then there's this interaction between receptors called PDL1 or PDL2 and then PD1, and they connect with each other. PD1 is on the immune cell side and PDL1 is on the tumor side, and they connect and shake hands. And when that happens, it actually is a reassuring thing for the tumor cell. Says, I belong here, nothing to see here, I'm no threat to you. It's kind of like the magnetic badge I use to get into my clinic. But you can make counterfeits, and that's what the tumor does. The tumor has these ID badges that it shouldn't have, but that's what this PDL1 protein is kind of like. It's a protein on the cancer cells that tells it's an invisibility cloak, essentially, that tells the immune system, I belong here, go on to your business. On the top is a different area where the immune system works, which is actually inside lymph nodes. The lymph nodes that you have largely up and down your trunk and your neck, armpits and mid-chest and lungs and your groin, etc. You have a lot of them throughout your body. Those are like the corners of your gutters where everything meets. And that's where you have these DC, this spiky cell. That's a dendritic cell. That's a big teacher cell for the immune system. And that interacts with the T cells, the actual muscle that goes out there. And the dendritic cells interact with the T cells to say, this is the peptide you need to go looking for, go get it. And that happens not necessarily where the tumor is, but in the lymph nodes. So that's just like, the police academy, before you go out during the day and, be careful out there. That happens in the lymph nodes. And there's a different interaction. That's with CTLA4 with another marker. So CTLA4 is one of those other receptors. And there are medications that will block the CTLA4 part and therefore will help stimulate the immune system by modulating what happens in the lymph node. And then there are these checkpoint inhibitors that block this, and they can block either side of the PD1 or the PDL1, but they essentially do the same thing, because if you block either part of that handshake, it turns off a braking mechanism, and that's the key thing. So when you turn off one of the brakes, it tips the scale in favor of stimulating the immune system, which we hope is going to lead to the cancer being able to better recognize and attack the cancer. That's the idea of many of these drugs. And there are some studies that combine the drugs that work at the tumor and T cell part, PD-1 or PD-L1 inhibitors, with CTLA-4 inhibitors. So different parts of the immune system can be targeted with different drugs, and that's what we are living and learning about right now. So let's move on. Next slide.
Before we move on to the next phase, does anybody have any questions? Just for some of the new people in the room, I want you to know we want this to be very interactive. So if we do not have to wait to the end, and it goes for the same for the folks online, to ask questions. So does anybody have any questions about the I love the handshake analogy. We've talked about this a lot, and the nothing to see here, that made a lot of sense to me. But please ask questions. Feel free. Fred, do you have a mic? Just, yeah.
You want to use
We grab your mic, Fred, just so everybody can hear you. Sorry. Oh, we got two over here, Betty. Thank you.
Steve.
Could you elaborate a little bit more on how the CTL1...
CTLA-4.
Or CTLA-4, or whatever, yeah, the CT, works, with the lymph nodes?
Well, basically, it's the same concept of turning off one of the braking mechanisms there, except there it's between the dendritic cells, which are kind of the teachers of the immune system, and the what are called the effector cells. So so it's between the teachers and the actual workers, and it just is in a different, literally a different part of the body, and a different part of how the immune system works. One is in the here's what you have to look for phase, and the other is in the hey, is that you? I think I saw from the from the picture this morning.
So by blocking the CT link, you're altering the T cell to attack the cancer cell?
You are, and these drugs have similar effects. We don't yet have a standard treatment for lung cancer that blocks that, but it's used in kidney cancer and melanoma, a drug called Yervoy or ipilimumab. But these drugs have some side effect challenges that are not trivial. They can get you in a hospital, and so they may be beneficial. We're looking at that question, but today it's not a standard treatment in the setting of lung cancer yet, because we are always trying to figure out, is this side effect, is the treatment worse than the disease? And also, is a combination like this better than the various other treatment approaches that we might do, including just focusing on the PD-L1 portion or chemo combined with that? These are all in the universe of things we're testing right now in the clinic.
And what Dr. West is getting to is that when all of this works properly, immunotherapy actually wakes up the immune system and it says, get to work, cancer's here. And it's your job to get rid of it.
Right, exactly. So that's if it works.
If it works.
So I have a question based on what we're saying. So some of the drugs out there are approved based on PD-L1 levels.
Right.
Some aren't.
Right.
Why?
Okay, well, the practical answer is because they were tested and they seem to work or they don't seem to work as well in different groups. This is very controversial because different companies have just prioritized different ways of looking at their drugs. Some have cast a very wide net and not been very selective about whether they're looking just in the people most likely to benefit, and some have focused more in the patients most likely to benefit and then maybe expand from there. So it's largely due to the vagaries of how the trials have been designed and what has actually worked. And then if they worked, they get approvals based on what was done in the trial. So we've talked about this PD-L1. You saw a kind of cartoon version of it, but it's just a protein that is on cancer cells sometimes. Not every cancer cell not every tumor has cancer cells that have this protein. Some have a lot on most or all of their cancer cells, and some tumors have some on some of their cancer cells, and some have none anywhere, and that's shown here. This is staining patterns, it's called a TPS, or tumor proportion score, of essentially 0 or less than 1%. So it's just what proportion of the cancer cells have this protein on it, which stains brown. This is one magnification, and this is a more detailed magnification, so you can more see the outline of the individual cells. But lots, a little, or none. And so different studies have included anything from all of the patients across the spectrum to just focusing on the patients with the highest level of the protein, to sometimes just some or a lot, but not including those with none. It's been everything, and different companies have had different priorities for this. It's about a third, a third, a third in proportion. It's somewhere in that range, about 30%, and about, so it's very close to a third, a third, a third as a basic breakdown. And this PD-L1 is, as I say, just like the security badge, false sense of reassurance. And what we've generally seen as a rule is that the patients who have tumors with the highest level of expression have tended to be the ones with the highest chance of responding well to immune therapies for the longest period of time. Let's move on. So the challenge is, this is one of the big benefits of immune therapy, is that you can get dramatic and long-lasting responses. And in large part, many patients can feel great on this and have no side effects. The most common side effects we see are a little fatigue, maybe a rash, or nothing at all. But there's no treatment for cancer that is risk-free. And immune therapy is no different. The immune side effects are just very different from chemo, and those are very different from targeted therapies like Tarceva and the ALK inhibitors, et cetera. So they're different, but the immune therapies, of which there are several drugs that we're going to be hearing about, you'll see on TV, et cetera, all share remarkably similar side effect profiles. And as I said, in most patients, they're mild, but a minority of patients can have more serious side effects, and they're the double-edged sword of stimulating the immune system. It's the immune system attacking bystander parts of your body. And the problem is, just about anything can happen. Anything with an itis after it, dermatitis, colitis, nephritis, these are all just the words for inflammation of the skin, inflammation of the lungs, inflammation of the liver, inflammation of the kidneys. You can have just about anything get inflamed from your immune system getting confused and going after a bystander cells in an organ. But the liver, the kidneys, the colon, the lungs, the thyroid, various other glands like the adrenals, these are all things that can happen. And there's a very long list of 1% or less possibilities. Most of these are about 1 or 2% chance of being more significant. But when you put them all together, it's somewhere in the range of 10 to 20% of patients need to take breaks from or stop immune therapies because their immune system is causing problems. And I've had patients who have to stop because they get inflammation in their lungs or their kidneys are bothered by this. And very often, if you stop the treatment, that just gradually gets better. Sometimes we need to give steroids to stimulate or to suppress the immune system. And when you give the steroids, that tends to cool things down. And sometimes you taper them off and you can gently try again, or sometimes you stop. But I cannot say that this is, you just can't say, here's a list of the 5 things that will happen or could happen. This is not like EGFR inhibitors, the drugs like Tarceva where you basically have rash, diarrhea issues, nail and hair things, but it's a pretty short list. This is an entire universe of potential things that could happen, but most of them are 1% risks. Next slide. Just showing that in another way. All these various tissues can have inflammation, and you could end up in rare cases with diarrhea that puts you in the hospital. That's something that Yervoy or ipilimumab occasionally does. You can even get diabetes or numbness and tingling from nerve damage. I've not seen most of those, but they're occasional things that a person might see once every few years, and it's certainly something that could happen. So I know there's a question.
Warren, you have a question? Do you have the mic? Oh, Bridget, there you go, Fred. Thank you.
I had a question on two previous slides. Do you know the mechanism or the reason why T cells don't attack tumors that have 0% PD-L1 expression, if that's the primary protein that's fooling the T cells?
It's not the only thing. That's just the issue. I mean, as I alluded to, but very simply, it's a very complex array of things that are controlling both stimulating and inhibiting the immune system or the clotting balance. It's PD-L1 is just one of many factors. And so presumably for those patients who have no PD-L1 expression that we see, there's other mechanisms involved that help the tumor evade the immune system. But this isn't just one binary yes or no, you have it or you don't. It's not, there isn't just one thing controlling the immune system here. It works if the immune system is, or if the cancer is really relying on this cloaking device and you take that away. But for the tumors that are not relying much on PD-L1 or not at all, it doesn't matter whether you take that away or not. They didn't care. They weren't using it before. So that's obviously simplified, but the other answer is we don't know all of it yet.
So that's what I was going to comment. I mean, I think as exciting a time as this immunotherapy space is, we're so new to it and the whys behind.
Yeah. I mean, I'm going to talk next about, where this actually entered into lung cancer treatment, but though it's now old news, it's not that old news. This is immune therapies really came on the scene around 2013 and 2014. And so we've gone light years since then, but it's been a wild ride. And so we are still learning as we go all the time.
I think we have an online question. Yeah. Oh, did you want to make a comment
first? That's okay. Go ahead.
Go ahead.
So Melissa's wondering, does the PD-L1 number change with progression? In other words, she has 40% at diagnosis. Will that change?
It can. It's, first of all, there is some work that suggests there's some variability depending on whether you biopsy, one part or the other part of the cancer. And yes, it can shift over time. I don't know that it's going to matter that much because you can get immune therapies if you're eligible at all. If you don't get it as first treatment, you'll likely get it as second or third. It's not a question of if, but just when. And so if you didn't get it as your first treatment, whether it's 40%, 30%, 50%, or more or less, you're still going to be qualified to get it whenever you can get it. There are plenty of drugs that are approved, and that level is positive enough to cover a lot of cutoffs.
So basically, immunotherapy is in the future at some, or in the...
Yeah, and so I would say if somebody has a biopsy and isn't on immune therapy now, and then it would be an appropriate second-line treatment, there's not really a good reason to do another biopsy if no matter what the result is, you're still going to do the same treatment. Why do anything with any risk associated with it or discomfort or cost or whatever if no matter what the question is or no matter what the answer is, you're still going to do the exact same thing?
And I think if we look at this as personalized medicine and your physician choosing various different treatments for you, either based on markers or genomic profiling that you've had or don't have, because we've seen this work on people that have none of the markers. You know, they don't have PD-L1 and they don't have PD-L1.
No, and that's another thing. This is, you'll see as we go on, PD-L1 is not an amazing biomarker. We've been critical of it. We're still learning. But it's not like EGFR, which is itself not perfect. But if you have one of the common EGFR mutations like an exon 19 deletion, your chance of responding to these drugs for it are 70 to 80%. Very good, but even that's not 100%. But in our patients with high-level PD-L1, the response rate's about 50%. It's even a little shy of that. So that's not 75 or 80%. And if it's 0, you can still benefit. And so that's why if it's neither necessary nor sufficient, it's really just helping us prioritize, should you get it as your first treatment? Should you get it as your second or third treatment? Should you get it alone or in combination with other things?
So and I don't want to jump ahead, I didn't get a chance to look at your slides. Are you going to talk about mutational burden and what role that plays?
A little bit, yeah.
Okay.
Next. So this is where things started. Publication in 2015, a couple of them, from work done in 2013 and 14. 2 different trials, and they are patients who have gotten prior chemotherapy and were then moving on to a second treatment. And the standard older treatment regimen that is still FDA approved and has a survival benefit is a drug called Taxotere or docetaxel. And that was what we call the control arm. So half the people got that, and half the people got Opdivo, also known as nivolumab. And the trials were essentially the same trial, but, sorry, the numbers, there's a smaller number of people. This should be, one is squamous and one is non-squamous. I'm sorry I copied that incorrectly. But they're essentially the same exact design. Just one group of people had squamous cancer, which is about 20 or 25% of what's out there as non-small cell. And the other group of patients had non-squamous, which is the other 75% or so. They were otherwise the same study, and they both had the same results, which is that you had a clear survival benefit and a higher response rate and a longer time until progression in general in the patients who got Opdivo, and fewer side effects. Taxotere can be a challenging one, and as I said, though Opdivo wasn't a freebie in terms of side effects, it was easier, and people lived longer. And it was many months longer on average, with some doing way better. In fact, I have a patient who is on one of these original trials who just is now 5.5 years out with no evidence of her cancer. And she was going to go on hospice if this didn't work out, either if she couldn't get on the trial or if she progressed on it. Yeah. This wasn't a slow process. Her cancer was pretty virulent, and it stopped cold. It got so much better that she came back a week later and said, I think my pain's getting better. And I thought, well, that's the placebo effect, because I don't think it's going to work in a week. But she was right. It just kept getting better. She kept cutting back on her pain medication, and by her scan, it was better. And then her next scan was better still, and it kept getting better. And now we can't find any evidence of her cancers. And one of the other exciting things about it is, as I said, how long it can work.
And what line treatment was that for this
second
particular?
Line. This was second line.
So first line, did she have a targeted marker? Or?
She did not.
Nothing.
She has a squamous cancer.
Okay.
And so her cancer grew right through it. And sometimes we see that people who seem to respond best to these therapies did poorly on chemo. And so you just never know.
Yeah.
I'd like to say that that's the way most or all of my patients did, but unfortunately that's not the case. But it's exciting to know what's possible. Let's move on. So what we ended up with was first Opdivo, and then Keytruda, studied a little after that, and then another drug called Tecentriq or atezolizumab. These are all similar drugs. Two of them, Opdivo and Keytruda, work as blocking PD-1, and Tecentriq blocks the other side of it, PD-L1. But they had the same results, essentially. They all directly compared to Taxotere in the same kind of populations, and they all had a survival benefit and very similar side effect profiles compared to each other. And they all got approved with slightly different requirements. Two of them are Opdivo and Tecentriq do not have any requirement for any level of PD-L1, and Keytruda was initially studied in only PD-L1 positives and where it was a beneficial treatment, and so it was approved just for that as a second-line treatment.
How about on the first one on Opdivo, which is every 2 weeks versus 3 weeks on the second two, was that a higher dosage or a lower dosage?
I'm sorry, for which?
On Opdivo, on the first one, every 2 weeks.
Yeah. It's kind of apples and oranges.
Yeah.
I mean, they
Dosage
ended up getting the same results, but they have somewhat different half-lives, and so they ended up, which means how long they stay in your system afterwards. So they've just been developed with different schedules, and they change, and the dosing has evolved as they've gotten more experience. But Opdivo was every 2 weeks and is now FDA approved to be twice as much, half as often, so it can be given every 4 weeks. The others are every 3 weeks, and so this is going to change as we learn how we can safely give them with as minimal inconvenience as possible so that people aren't tethered to the clinic all the time. So they all have very similar efficacy. I wrote 20% response rate or so, 15-20% in the second line, and that's the rate where the cancer shrinks significantly by about half. A lot of patients, more than 20%, will benefit. And that can be a little bit of shrinkage or stable disease when the cancer would otherwise be growing. And another thing that's worth knowing about immune therapy is that the scans are a little less helpful, or can be less helpful than they are when watching what they do on targeted therapy or chemo, where they shrink or they grow and that's it. With immune therapy, there's a concept called pseudo-progression, which is when the scan looks a little worse, but the patient's doing better. And it's not common. And it's a mistake to presume that every time you see the scan look worse, it's because you're being faked out. But it is important to see and incorporate how the patient's actually doing, because just today I saw a patient who had their first scan looked maybe a little worse, but his pain was less and he was gaining weight back after losing a lot of weight. It just didn't fit. And with further follow-up, I saw he just had a scan again. His second scan was a few weeks ago. It was way better. And so you don't want to throw out the baby with the bathwater. And so if the scan and the person and their story don't fit, give the patient the benefit of the doubt and keep going. What you don't want to do is have the scan look worse, the patient more in pain and losing more weight and saying, it must be pseudo-progression, let's keep going. You don't want to just chase good time after bad. I mean, you've got perhaps other options, but you don't want to just beat on a bad treatment.
And it could be inflammation or maybe even calibration on the CT scanner.
So why is it that you would have a scan that looks worse? They've biopsied these sometimes. And in fact, that patient who's more than 5 years out had some lymph nodes that got bigger even as her main tumor was getting smaller, and I didn't buy it. And so she had a biopsy, and it was essentially raging inflammation. So what you can have is the scan looks worse because the cancer doesn't have more cancer cells in it, but it's now surrounded by immune cells. So, it's like an aerial view of protesters and counter-protesters. And if you have enough counter-protesters, it's going to look like a bigger crowd. Yeah. And so what happens is later they will start to attack and erode the cancer, and it shrinks. But the first couple of months may look a little worse before it looks better.
I think this is a really important point. And Fred, I know you've had experience with this pseudo progression, because I don't know how common that might be.
It's debatable. I mean, in general, because I've just done some surveys of thought leader specialists and community oncologists, and there's a clear difference that community oncologists think it's way more common, and thought leader specialists in lung cancer think it's rare. I think we don't want to get that simplistic about it, because honestly, the more I see it, or the more experience I have with it, the more common I think it is. It's not most people, but I also don't think we should say it's so rare you shouldn't even consider it. Right. It's more than a trivial amount. It might be, it might be 10, 15%. And so this is something where I think that the party line, even by the lung cancer specialists, may be wrong. That as we characterize this better and actually measure and look, we'll find that it's not a trivial minority of patients, though you don't want to cavalierly say, if the scan looks better, keep going with the immune therapy. If the scan looks worse, it's pseudoprogression, keep going. I mean, you don't want to be so bullheaded that it's always immune therapy must be working. I just won't believe it. You know?
I think it's important. It's again important to kind of point out for people in the room, people who will come back and watch later, people online, to keep an eye on, you know, where this kind of goes with this pseudoprogression. The more we learn about it, as something to have a conversation with your physician about. Right. Given that most people will wind up on immunotherapy at some point during.
Yes, but I think that the key is you need to be open-minded about it, but you can't be so biased that you're just hell-bent on staying on immune therapy. It's not in your best interest if you're getting worse and the scan's looking worse. That is not a good choice, and so we just need to be mindful of the possibility of this, but not be so tainted that we will automatically interpret anything as I'm still going.
Correct.
So let's move on.
One question here.
Okay.
Oh, go ahead, Robert. Will you grab a mic? Sorry. Betty, will you grab, or somebody?
We're good, we're good.
You had a mic.
Danielle said at some point, you know, everybody's going to end up on immunotherapy. When should you introduce that into your treatment? My doctor
it depends on the person. First of all, I wouldn't say everybody. There are some people with autoimmune disorders who could be harmed by it. I do have a patient with ulcerative colitis. Other people have had serious or life-threatening problems, and it's maybe 5 or 10% of our population. It's one thing to take it if you have rheumatoid arthritis and it's not that big a deal, and if it's worse, you'll have joint pain. But we don't want to give people life-threatening autoimmune problems by turning the immune system on tilt, okay? So, but most patients will be able to get it. I'll get to the kind of who should get it first, who should get it second, who should get it third, and then there's a question of who should maybe get it never. Yeah.
Also, isn't it true that you shouldn't, like, when to introduce it? I mean, if it's going to be something that's a good option for a patient, it's never a good idea, because and I will say this because patients call all the time because they see the commercials, and even if they're on treatments that are working, they're like, I want immunotherapy now.
Now, that is true. I would say, you know, if you're cured, don't do immunotherapy. It's not at this point for patients with early stage resected cancers. It's not absolutely at this point indicated for small cell or mesothelioma. And as I said, there's a minority of patients for whom it may be a bad idea. And there's many patients for whom other treatments are a better idea, namely the patients with driver mutations like EGFR and ALK and ROS1, where we have therapies that have a very high response rate that work for a very long time, and immunotherapy is not a better choice than that, and we shouldn't just chase down a rabbit hole because it's a shiny new thing. And just being on TV doesn't make it the better treatment. So it is not the right tool for every job. It is very good for some, of some utility for many and of no utility for a few.
And your physician is going to make decisions for you very personally based on everything that's going on in your body, and not just including your cancer, including other things that might be happening to you. And that's really what personalized medicine is today. And those are good times for second opinions too. If you've progressed and it's time to make a change, it's a good time to go out and get a second opinion, so you get consensus on what's happening with you.
I think Ron has a question.
Thanks very much for sharing your information and presenting it in a layperson's language. So we'll much appreciate it. I had two questions, and I'll see if I can remember them. The first one relates to this bias that we all have. I agree that the personalized medicine from our local physician is important, but sometimes they're stuck. They have to follow guidelines or they have to follow insurance rules. And so one of the rules that came out recently that I'm curious about your opinion would be on nivolumab, this idea of going from a weight-based dosage to just being a fixed dosage based on frequency.
That is something that has evolved. I don't think there's a wrong answer to it. These earliest studies were done based on weight, and it's evolved to a fixed dose. The secret answer is I don't care. I don't think if they both work pretty comparably. The more recent studies have adopted a fixed dose, and I don't feel very strongly. I don't think insurers are wildly pushing for anything, but I don't think there's any tyranny about that. I think it's just a judgment, or it's just shifted from that was the old way we did it, and we found that the new way is simpler and works every bit as well, so let's just do that. But I do the weight-based dosing. I do the fixed dosing, and most of the other immune therapies have just shifted toward that as well as a simpler idea. But I don't think there's anything more to it than just trying to keep it simple.
Do you adjust dosage to consider side effects if somebody's having a hard time?
No, I don't. We haven't seen any good evidence that you can dose modify and do better. It's that I think with the side effects, it's either you have it or you don't. You stop or you don't, or you add steroids or you don't, and those are the main nuances of it. But I'm not sure that I don't think I've seen any evidence that if you just cut it by 25% like you would with chemo or a targeted therapy, that you could go under that threshold and not have that problem anymore.
My second question, it's hard to remember when you did your taxes today.
Oh, good for you, you did them.
I did do them. Joan would be proud. The second question goes to the fact that the studies indicate, frequency and this fixed dosage seems to work just as well as weight-based. But I'm concerned is that if you look at the population of who gets cancer, a fair percentage of them are older and smaller people. And the trials don't seem to have a population base that stretches out that far in that population base. Or am I wrong in understanding that?
No, it's fair to say that the median age in most of these trials is at least 5 up to 10 years younger, usually about 7, 8 years younger than the median ages of patients with cancer in the broader population. But a lot of these we do get results from registries that look at broader populations, and to my knowledge, there haven't been any discordances between what the trials would have and what other studies do. This has been pretty consistent in other cultures. I mean, I was just in Chicago for this big meeting, and there was a Chinese study that was essentially the same thing as it was Taxotere versus Opdivo, and just showed you get the same thing in China. So to me, I'm honestly reassured that it doesn't matter how you look at it. You can look at it in China, in the U.S., in squamous and non-squamous, and the results are really more similar than different. I don't have a horse in the race on this, but I don't think that the the weight-based issue is something that I would, I'm just not inclined to put too fine a point on it. I don't think we've seen much evidence that it matters that much. I mean, basically, the people who have cancers that respond well, if you give what is anywhere in the ballpark of a typical dose, they'll either respond or they won't respond. As I said, it's neither the efficacy nor the toxicity seem to be within the range that we're usually operating in, that dose dependent.
Yeah.
Thank you.
So
thanks, Ron.
Let's move on. I want to get to, as we've, next slide. So a couple of years ago, immune therapy started to move into the first line setting, and it was based first on this trial, which is called Keynote 024, and it was with Keytruda, and they took patients who had 50% or higher level PD-L1 expression, which is, as I showed here, about 28 to 30% of patients. They excluded patients with an EGFR mutation or ALK rearrangement. That wasn't a punishment. That was a recognition of two things. One, that the drugs that were available for these patients worked really well, and they did not presume that this would be better than that. Second, the earliest indicators were that the immunotherapy drugs maybe didn't work that well in these patients, and we'll talk more about that. But this was a little over 300 patients who did not have an EGFR mutation or ALK rearrangement and who had high-level PD-L1. You could have squamous or non-squamous lung cancer, and they were randomized between various chemo doublets, two-drug combination, which would be a standard, or half the patients getting Keytruda every 3 weeks. And then if patients had progressed on chemo, you could go on to Keytruda after. And Keytruda was overwhelmingly better for response rate, which nearly 50%, very much longer time before the cancer progressed, better overall survival, and some of these patients still doing well without progressing even a couple of years in. And this was a huge hoopla when it was presented in late 2016, and just 3 weeks after that, the FDA approved it as a first-line treatment for this population. And that meant that we now needed to do PD-L1 testing right at diagnosis. Otherwise, you didn't have to do it, because in the second line, 2 of the 3 drugs you could give whether you were high or low or didn't matter. So why test? And so a lot of us didn't, and that was not wrong. But now it changed the equation, because you had a potentially very attractive option with fewer side effects than standard chemotherapy that could work a long time, but it was only appropriate for the people with high PD-L1, that 28 to 30%. Next slide. And at that same meeting, there was a presentation of another option. You know, this prior trial was, do you give Keytruda? Do you give chemo? Which should you do? Well, maybe it's not an either or, but an and. And so this trial was just for patients with non-squamous histology, again excluding patients with EGFR or ALK mutation. And because Alimta really only works in non-squamous, that's why this was for that. And it was carbo and Alimta, a very, very commonly used, favored, well-tolerated regimen as a standard, or the same with Keytruda every 3 weeks. And then patients could continue on a combination of Alimta and Keytruda after 4 cycles, or Alimta alone if you didn't get the Keytruda side, and then you could cross over. And this was not a large study. This was 123 patients. Our bigger randomized studies are called phase 3s that are kind of practice-changing potentially. This was a phase 2 or a randomized phase 2, which is interesting, but not necessarily enough to change practice. But the differences were quite significant, favoring the chemo and immune therapy combination, at least for higher response rate and longer time before the cancer progressed. The early version of when they presented this didn't show a difference in survival, and most lung cancer specialists said, interesting, but we need more evidence. And the FDA approved the regimen, the 3-drug regimen, in May of last year based on this trial. And many lung cancer experts and general oncologists alike have not embraced this, even though you could do it, because you're just really combining 2 potential treatment approaches all at once. And it's not necessarily the case that it's inherently better to compress 2 treatment approaches all in the first few months of treatment if you can spread out the side effects and spread out the options and leave something in your back pocket. I think one of the challenges of giving all this up front is, you're using a lot of the arrows in your quiver right off the bat, and if a patient progresses, you're more limited.
Yeah.
And so you could argue, well, why should I use more than I need at the time to do the job? And because of that, it has been an open possibility, but not necessarily something that most oncologists heartily embraced, even if you had the FDA approval and could do it. And not surprisingly, you have more side effects. You get the combination of the typical side effects of chemo and the possible side effects, uncommon but seen with immune therapy, all mashed together. And you don't know. One of the other questions I've had is, when you give ongoing chemo, 1 drug, Alimta, with Keytruda, and a patient's doing well, you don't know which drug's doing the heavy lifting and which is just along for the ride. An expensive ride. These are pricey drugs with potentially significant side effects, especially as you keep going and going and going. It's one thing if you're giving them and you know they're working. It's another if you're giving one as a ritual and the other is doing the job and you can't tell which. So this is an issue, and this is an option that's been out there for just under a year. Next slide. And this changed yesterday. This was a presentation called Keynote 189. You might have seen it in the paper. I got mentioned in the Washington Post coverage of this stuff. But this was a really practice-changing result. A lot of us, as I said, were saying, let's see more data. We got more data. This is a phase 3 study, bigger, over 600 patients, non-squamous. This enrolled patients with any level of PD-L1, as the phase 2 did. You didn't have to have high level. You could be anywhere from 0 to a lot. And again, EGFR and ALK positive not included. We still weren't confident that you could do better. And patients could get cisplatin or carboplatin with Alimta. Again, the limitation to non-squamous because of the Alimta. And it was just chemo alone versus chemo with Keytruda, and then maintenance with 1 or 2 drugs. And you could cross over. And this was, we had already heard from a press release it was positive. What we didn't know was how positive, and this was screamingly positive.
50%.
Yeah, this was over 50% improvement in your probability of being alive over the whole time of what we've been following patients. So that is big. That's as much as you ever see in a lung cancer trial. So
huge.
Not subtle and very important, and no big surprises. A little higher rates of kidney problems with the combination of 3 drugs than they would have expected from Keytruda alone, but it's still 2%, so it's not awful. And because of this, now we already have the regimens approved by the FDA for this population, but it now tips the scale that, yeah, this is likely to be a preferred way to go and not just a niche approach for a subset of patients. And so this is attractive. And I think that we will soon see far, far more patients who are eligible for it getting it. Next slide.
As a sidebar to what Dr. West was just talking about, we have in the queue the link to the Washington Post article where he is quoted that you will all be receiving in the email. So be on the lookout for it. Yeah.
You can tell everyone you saw me today. Okay. So, but the other thing is, this is still in the context of more and more trials that are just rolling in, and they're positive. This is another trial with a Roche Genentech drug, Tecentriq, and it's basically 3 arms, chemo with Avastin versus chemo with Avastin and Tecentriq, and then the top arm is chemo with Tecentriq immune therapy, but no Avastin. And the main thing that they've shown so far is that adding Tecentriq to the 3-drug combination gave a significant benefit as well. This is pretty similar to what we got from the other Keynote trials with Keytruda, and it's an option. One thing that's different about this is they allowed patients with an EGFR mutation or an ALK rearrangement, but not as first treatment. This was after you had gotten and progressed on your targeted therapy. Then this was kind of the first backup after that. And the most interesting thing I think about this trial was the 14% of patients who were EGFR or ALK positive got the same relative benefit from adding immune therapy to the chemo that everyone else got. And in fact, they showed at a curve of the survival yesterday at the presentation, a little update, that showed the exon 19 patients who got a very big benefit.
Which is very good.
Yes, well, and so it just shows maybe we don't know as much as we thought we did, because the going story was these drugs don't work for these patients. Well, be careful. It's never that simple as we get more information.
So how would this look on EGFR mutant patients progressing on Tagrisso and going to?
It's a thought. I mean, the issue is that the chemo backbone in this is carbo and paclitaxel or Taxol with Avastin. It's not one that we are as likely to embrace as carbo paclitaxel or carbo Alimta and Keytruda, which is not what was studied here. But the question that we don't know is this just something that we can presume chemo plus immune therapy works for patients with driver mutations? Is it maybe the Avastin part of it?
Right.
I think a lot of people are still going to prefer to give the Alimta and carbo Alimta Keytruda, which is a bit like the street lamp effect of the drunk who lost his keys in the dark alley but decided to look for them in the well-lit street because the light's better there.
Right.
We say, well, I like giving carbo Alimta and Keytruda, so I'm going to use the regimen I'm going to use the principle but not the actual regimen. I think some will do that and some will do this. I think that most oncologists will not be inclined to use this regimen for people who don't have an EGFR ALK. I think that some will use this for that, and some will use other regimens, and we still need to learn more. But I think the biggest story is it is wrong to presume that these drugs don't work for patients with
exactly.
And I think, Joanne, you brought it up during the introductions, right? Because previously the thought process was it doesn't.
No, and again, it was right at the time based on what we knew at the time. Yeah. But we're still learning, and this is going to open up a lot more research on these drugs for these patients. But this was the best we knew based on the little limited data we had available to us. And so you do what you can.
We always have to throw out. These are the reasons patients need to participate in clinical trials.
Right. I mean, this is a material change.
Yeah.
Next.
I think there's an online question, just real quick before we move.
Are there any negative markers such as MDM2 that indicate that you should not receive checkpoint inhibitors?
I would say nothing in clinical use right now. No, there's nothing that we would say is such a useful, reliable, negative predictive marker that it would be great to have something like that that could tell us, because again,
won't work.
Even in the higher groups, it tops out around 50%. So it's not a guarantee. It would be really valuable to know that this $15,000 a month drug will not work for you, or if you're not sure if the side effects are going to be worth it, maybe you've got some autoimmune problems. It would be great to know in 20%, this is just not the drug for you, period. And we don't have that today.
Right.
Let's move on.
Yep.
So this is why we had said that these drugs don't work. We actually didn't have essentially anything on ALK, but this is what's called a forest plot. And basically there's a line, a vertical line, and if the blips line up on one side or the other, it indicates that one treatment is better than the other. And so all of these different blips represent different trials of immune therapy versus chemo as second-line treatment. And what they show is that the patients who don't have an EGFR mutation in all of these trials consistently did better with immune therapy. The only variable based on patient characteristics, sex, age, whatever, the only thing that consistently falls out as different was patients with an EGFR mutation never got a benefit compared to chemo. And so in all of the trials, that's what we saw. And that's why, based on what we knew at the time, it seemed that this is not the treatment for these patients. Whether it is that they just don't work as a single drug, whether they need to be given with chemo or with Avastin, don't know yet.
So we've seen patients, and since we're talking about EGFR, we'll use that, with an EGFR mutation at the beginning of their cancer and their genomic profiling, that upon progression, somewhere along the way, maybe it's second line or third line, where all of a sudden now they have a HER2 or a MET or a RET.
Yeah.
How does that change the prognosis of immunotherapy?
Don't know. This study also looked at KRAS.
Okay.
Nothing's been studied very well.
Okay.
KRAS is common enough, it's been looked at. But ALK and ROS, they're just too rare. So
yeah.
They could at least speak to this. They couldn't even talk to any of the others. But we have largely drawn generalized principles from EGFR, ALK, ROS, because they're all seen in never smokers very commonly with adenocarcinomas. The biology is largely similar, but I don't think we should be that presumptuous about anything right now because we're just still learning. So this is just where we are. This is the story as of yesterday, but it's just caused us to step back, walk back the idea that these drugs don't work in patients with driver mutations, period. Now, one other thing I wanted to say is I know that you have an EGFR mutation and high PD-L1. It can happen. Most experts who have done studies with this say if you have EGFR, ALK, and high PD-L1, it doesn't have the same prognostic significance. So, in other words, it's still way better to focus on the targeted mutation than the immune therapy, which isn't to say that you couldn't and won't benefit. Maybe you'd be more likely than a lot of other people to benefit from immune therapy, but that it, particularly with ALK, it may not mean the same thing. Dr. Wakely, who's just down the road, is one of those people who has a lot of experience with this and says, I've got a lot of high PD-L1 patients with an ALK rearrangement or EGFR. Just don't see the good results with that. So don't know. We still need to learn more about this, and we can learn more by systematically studying it than just by collecting our impressions in the clinic.
And is it true that most of the patients that immunotherapy really works well with have no marker at all?
Yes, that's true. In fact, one of the things that I think is, as a general principle, most promising, exciting, interesting about immune therapy is that, as I mentioned with my one case of a huge responder, she didn't even respond to chemo. She had no driver mutation. There's some experiences, if not firm data, that suggest that some of the people who respond best to immune therapy respond least well to other things. So after years of having yet one more thing that works for never smokers with an adenocarcinoma, leaving all the people who are not in that group, like what's there for us? Right. This is something that is another source of hope. For anybody, it's a wild card, and I think that's really valuable. I mean, it's a scratch ticket that could change your life, and so there's always the hope. But the odds are better in the people who actually, ironically, have a smoking history, and not that you should start smoking for this. But okay, next slide.
Wouldn't that be ridiculous?
Yeah.
Somebody actually asked that question.
That is not my message.
Right.
Okay. So we're getting to the realm of this is so timely. We're now in the future. Okay, this is a press release about a trial called Empower 131, another Roche study. This is looking at patients with squamous lung cancer. I'm sorry, I meant to update with the number of people on it. I don't remember what it was. It's a few hundred. And so it was basically carboplatin and Abraxane, which is nab-paclitaxel, either alone or with Tecentriq immune therapy or a different chemo and Tecentriq combination. And so they've designed a lot of their studies to look at 2 or 3 different things at once. And so this is not an FDA-approved regimen, but we know that it's positive for survival benefit, I believe. So this is something that I think we will be seeing at ASCO and is likely to present a compelling option for the patients with squamous histology, at least for those who don't have high PD-L1. This did not have a PD-L1 cutoff. So I think this is going to be a very strong option for patients with squamous if you don't have high enough PD-L1 to favor just doing Keytruda alone. Next. Another projection into the near-term future. This is from Merck. Darn, I really need to have the number of, excuse me, folks, for not having that. I haven't slept yet in days. So, but anyway, this study is called Keynote 042. It's essentially the same study as Keynote 024, which was chemo versus Keytruda. The old one was a cutoff of 50%. This is a cutoff of 1%. So now you're looking at 2/3 of the patients out there, squamous or non-squamous, and it's positive for an overall survival benefit. And so one of the biggest competing ideas for the combination of chemo and immune therapy with Keytruda is going to be just the Keytruda. That's going to be a strong option for the patients who are anything from 1% to 100% PD-L1. It's not going to be the treatment of choice for people with 0% based on what we know now. It's not FDA approved. We have not seen the results yet. I think we will be seeing them at ASCO, which is the American Society for Clinical Oncology annual meeting, right the week after Memorial Day. So it's going to compete with the chemo, Keytruda, and other potential immunotherapy combinations. Let's move on. Tumor mutation burden is something you've already mentioned, and so it's out there in the chatter. What is it? Well, it's just a measure of how many different mutations your cancer has in it. It's the idea is that never smokers often have one main mutation. That's the driver mutation. EGFR or ALK is just like, it doesn't have to cause a lot of damage to the system. If you have one rat nibbling the right wire, it'll bring down the whole system. And so, on the other hand, if you find and attack that Achilles heel, you can really bring the cancer to its knees a long time. So those are cancers that generally have relatively few mutations. They're just 1 or 2 really powerful drivers. And so the key idea is these are all different kinds of cancer. This is leukemia, carcinoids, prostate, breast, etc. And on this side are lung cancer, adeno and squamous, and melanoma. And what's interesting is and then the vertical portion is the range of how many mutations these have. So what you should get from this is that different kinds of cancer have different levels of complexity on average. And as you would expect, every kind of cancer has a range of some within that are way high and others that are low. In general, like PD-L1, the cancers with high tumor mutation burdens are the ones most likely to be recognized by the immune system. And I think of it like the EGFR mutation's like a ninja in the shadows. I mean, again, I have to revise this now that we've seen some evidence that they can benefit, but we previously thought that these drugs don't work for patients with driver mutations, and the idea is that if you have one really doing the damage, it can hide effectively from the surveillance. On the other hand, tumor mutation burden that is high is like tracking a riot, a mob of mutations. It's not any one mutation causing the damage with most squamous cancers or lots of others. It's actually lots of cancers each doing a little damage, and so you can't take it out with one shot. But that also makes it much harder for the mob to evade the immune system because it's everywhere to see.
So to look for high mutation burden, a patient would want their physician to give them what kind of a genomic test?
It's done through Foundation Medicine and others, but Foundation is the best studied. One of the cautions I would offer about this is it's not totally reliable. There's not one universal yardstick for this. And in fact, the discussant after a presentation I'm going to talk about, who put this in context as a major expert, said, this is not ready for primetime use in the clinic yet. It's debatable, but this is somebody who eats, sleeps, lives, and breathes this. And his sense was that we still have not characterized this. It's still not robust or reliable enough to use as a clinical tool routinely. And so that's a caveat that I would say it is not yet part of any algorithm for how to treat patients well. But let me talk about why you'd think about it. Next slide. So this is a study called Checkmate 227. It was quite complex. It was actually 2 different sub-studies, one for patients with PD-L1 expression and one smaller one for the people with no PD-L1 expression. And they each part randomized patients between chemo of a few different kinds, Opdivo alone, or Opdivo and Yervoy together. And that's how they designed the trial. And then as it was being done, they started to see more evidence that tumor mutation burden seemed to be more predictive than anything else. And they changed it partway along and said, no, we're just going to pool the patients regardless of whether they have PD-L1 expression or not and focus on the patients with high tumor mutation burden, which using the cutoff that they found most effective was 44% of patients. Next slide. I'm sorry, go back, please. So what it showed was a significant improvement in progression-free survival and a trend toward better overall survival that was not significant at this point with the combination of Opdivo and Yervoy, which is a CTLA-4 inhibitor. And the side effect profile was about a lateral move to chemo. It wasn't at all toxicity free, and it wasn't less, but it wasn't screamingly more than you could do or handle. So that is an option that may be considered. I would say it was not the lead story. And in fact, what happened yesterday was based on all these reports that came out within 2 hours of each other, Merck's stock went way up and Bristol's stock went way down.
Right.
And this is a Bristol trial and the other one with Keytruda was whatever. So that is kind of the wisdom of the crowd's view of what this means. My view is it is encouraging to have an improvement in progression-free survival, the time before the cancer grows. But at the end of the day, what we want is to see this translate to more people living longer.
Right.
Particularly if it adds side effect issues and things like that. So what I feel is if this was a different time and this wasn't being presented right after a bigger trial, this would have been a bigger deal. But one thing I said yesterday was, you don't bring a knife to a gunfight. You don't bring PFS to an OS fight.
Right.
Overall survival trumps the other. It's a more important endpoint than this, and so this is good, but it's not great.
When you do clinical trials, we know a patient that was on this particular therapy that is a young lung cancer patient, high mutation burden, no other markers, 3 years out.
No, it's great. I mean, there are people. One thing I think is most interesting about this is when you look at the curves, which tell us how many people are alive at different time points, this looks like there are plenty of patients who are still alive and doing well at, say, 18 months in without progressing. It's not as clear that that's the case with some of the other trials, including the chemo-Keytruda ones.
Right.
They're kind of steadily going down without there being what we call a plateau, and which suggests that some of these patients may do really well for really long. I don't know. We need to learn more about this, and if I were Bristol, I would say let's focus on that and see if there's more people who are alive doing well at 2 years. That's an important finding.
Does it make sense to take these people on, like your patient and patients known to have done well on this particular trial and others, to do really, really small little trials with just those cohorts with maybe 3 to 5 patients or N of ones? To see?
Yeah, I mean, those are interesting proofs of principle, but I think that you'd want to kind of isolate the question from there and then test it in broader population. You don't need a huge study if you study the right patients and see dramatic differences. I mean, the crizotinib, Xalkori, was approved for ROS1 patients based on a couple of dozen patients.
Right.
But if you see a 70% response rate, that's real, and you don't need 300 patients to know it's real. So, but that's not, for this, we really need to pull back and see bigger. This is not screamingly obvious. It is not, at this point, an FDA-approved combination in lung cancer. I don't think we're going to be clamoring for it right now. We're already tripping over good options. And so, but this is one that is still a viable thing to be studying. I mean, there are some patients who probably could do very well with the combination, but with greater side effects than chemo and immune therapy, or at least comparable, and with definitely more side effects than just single immune therapy drugs. This is one that is not going to be exploding out there yet. Next
I hate to say this.
We're good.
Are we good?
You need to hold your questions.
Okay. Oh, I need to be quiet.
And we're winding down, but this is the scorecard for now. Just because there's so many drugs and indications. So the treatment I put on the left side, the various indications and other comments. So Keytruda now is approved for high-level PD-L1 first line. It's not yet approved, and this is just for first-line therapies. So approved for the high PD-L1 alone. It is not yet approved for the lower PD-L1 but positive. I think that's going to come soon. It's okay for squamous. It's okay for non-squamous. And a nice advantage of this or any other chemo or immune therapy alone is that you've still got chemo in your back pocket for later. It's got fewer side effects. Then you've got cisplatin or carboplatin with Alimta and Keytruda. And this is currently approved already based on a smaller study last year for non-squamous, excluding EGFR and ALK positive. It's generally well tolerated and has a very impressive survival benefit, but you've kind of blown first-line and second-line treatments all at once and have more limited options. But I still think that's a very appealing consideration for many. You've got carbotaxol, Avastin, and Tecentriq. It's not approved yet. It may well be. And that has been the groundbreaker for showing activity in the EGFR and ALK positives, may be a strong consideration as the next treatment after that. But for most people, it's kind of a lateral move. It just shows that there's nothing unique about carbo, Alimta, Keytruda, that it's not the only regimen that will work. We didn't expect that, frankly. But with Taxol causing hair loss and risk of numbness, tingling in your fingers or toes, I don't think it's going to be a more widely pursued treatment than carbo, Alimta, Keytruda. Then we have carboabraxane and Tecentriq, and that is likely to be a leading option for squamous lung cancer that doesn't have high PD-L1, but it's not approved today. It's going to be coming out based on what we've heard as a press release. And then there's Opdivo Yervoy, which has a PFS, progression-free survival benefit, not yet overall survival. It is only for the high tumor mutation burden. One of the other challenges I did want to mention about tumor mutation burden is it takes a few weeks to come back, and that's a practical issue. If it's going to take 2, 3, 4 weeks to get the result and start your treatment, many patients and many docs don't want to wait 3 to 4 weeks to start a first treatment if you've got other good options to consider. Just practically speaking, even if it's not an emergency, most patients are pretty anxious to get going within 2 or 3 weeks. It is a delay to get the result, but it does also have the advantage, like the various other immune therapy alone, of saving the chemo option. So next, and this may be, I just want to turn next to earlier stage, because this was a change with what's called the Pacific trial. It gives chemo and radiation and then randomized patients to immune therapy every 2 weeks called durvalumab or Imfinzi versus placebo as a 2-to-1 randomization. This showed a huge improvement in progression-free survival and is now FDA approved and a standard of care for patients who have gotten through chemo and radiation for stage 3 locally advanced lung cancer and haven't had their cancer progress and are still healthy enough to do something. We need to learn whether this is going to translate to a significant improvement in how many patients are cured. Next. And what I'm saying is, in this picture of an iceberg, is that the Pacific trial is the only one of these trials in earlier stage lung cancer that has been reported right now, but it's just the tip of the iceberg. There's lots of other studies looking at various immune therapies before or after surgery to see, or radiation, various approaches in a curative setting to see whether the benefits we've seen in stage 4 disease might translate to more people being cured with potentially curable cancer that we know is not curing enough. Next. Small cell lung cancer is also an area where there's plenty of interest in immune therapies. Thus far, most of what we've seen, this is a slide that you wouldn't want to study, but let me just, it was a reminder for me that various trials have looked at Opdivo or Opdivo with Yervoy, and these studies have generally shown that the results are better with the combination, and it is an option that is recommended to consider both or either of them for patients with small cell lung cancer that has progressed after, come back after initial treatment. It's not, it's being studied in other settings of small cell, but, and the results were best in the patients with high tumor mutation burden. This work has been also presented in the last couple of years. And so this is now in some of our guidelines for a good consideration. And very similar results have been seen in mesothelioma as well. That mesothelioma, we don't have good options for when it grows again after first treatment. And immune therapy, either one drug or 2 drugs, has looked encouraging, not for everybody, but for some. And a higher proportion respond and respond for longer with the 2-drug combination. Next slide. And then just to say that these are various studies that are looking at giving immune therapy after chemo, either as a maintenance therapy or other ways of integrating it or comparing it head-to-head to second-line chemo with a drug called topotecan that nobody likes. So looking at ways to either add to or replace some of our current standards that are not as impressive as we would like. Next. So just in summary, several agents are already approved and previously treated. They have appeared more similar than different. There are some differences, but most of us feel that they are close to interchangeable. Certainly, as second-line treatments, they have staggeringly similar results. They're moving increasingly into the first-line setting, and we're still learning about which patients are best served by getting immune therapy as a single drug first, which should be getting it with chemo, maybe some patients getting it in combination with 2 immune therapy drugs, but with greater toxicity. This is absolutely work in progress, literally changing day to day, week to week. And so that's great because we're only improving. We're subbing out something that looks pretty good for something looking even better. And then this is moving from advanced disease to earlier stage. Imfinzi, now approved and only a couple of months ago was approved as a new treatment that is becoming a standard for stage 3 lung cancer, may translate to more people being cured of this. And we are looking at different ways to use these drugs in earlier stage patients before or after surgery. And then Opdivo, with or without Yervoy, is being actively studied and increasingly used in small cell and mesothelioma. Next slide. And that's it. So stay tuned because this is all happening in real time.
That was awesome. So I think, thank you so much, Dr. West. I think, we've been talking about immunotherapy for, a few years, a couple of years now, and even back further than that when there were some vaccines and things going on that didn't quite work out the way we wanted them to or hoped they would. And it is such an exciting time, and for you to be able to come here and explain everything that's happening into, I can't remember who said it.
A lay language.
Into a lay language that people can really understand is huge, 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 because it is the thing to look out for and questions that we get all the time. So thank you very much. We've got about 3 minutes left before it's time for everybody to get up and grab some dessert. And of course, I have to do some housekeeping. Our next living room is May 10th in Chicago. So we are going out there. I don't know if there's flyers out there. Not that you guys here need them unless you plan on visiting Chicago. But it's all about personalizing your lung cancer. We've got Dr. Timothy Kruser and Dr. Nisha
Sequist.
Mohindra. There we go. Both from Northwestern. Okay. And Dr. Christopher Cedar from Rush to come out and talk about personalizing your lung cancer. I'm sure immunotherapy will be part of that as well. And then May 15th, our regularly scheduled living room here in San Carlos is our patient roundtable. So that's the one where we give you guys the opportunity to come and talk about you and really whatever you want. And I always tend to kind of get nervous about that one, thinking nobody's going to talk, and it winds up I'm always having to go, okay, people, it's time for dessert.
Well, how many people in the room are going to go to the Hope Summit, to Longevity's Hope Summit? Ron, okay. Well, Ron, you're going to be tasked with coming back in our next roundtable and giving a little talk about what you learned. How about that?
There you go. No pressure.
How about that?
I've learned it's very humid in Washington.
Yes, that's true. That's true. And then June 19th, our next San Carlos living room will be Dr. Blakely from UCSF talking about resistance to targeted therapies. So stay tuned for that one. Events that we have coming up next for those of you signing in or anybody in the room or those online who might know somebody in these areas, please contact us if you're interested. We have our Memphis 5K walk run April 21st. Columbus, Ohio is May 6th. Dallas, Texas, May 19th. Chicago, June 10th. And then here in Sacramento, June 23rd. Were you going to say something?
Nope.
Oh, I thought you were. Sorry? Oh, our golf tournament is June 11th here. anyone who's
Lots of golf.
interested in playing golf,
Come down.
up at Green Hills Country Club. It's a super fun day. So please inquire within. I'm going to go through thank yous again, of course. Thank you to Dr. West for scrambling all over the country and making it here tonight to be with us. All of our patients and the caregivers, those in the room, those online, and those who are going to come back and watch later, thank you, thank you, thank you. You are why we do this. Peninsula Television, yet again, for coming out and bringing all of their equipment and getting this all set up.
And the new lights.
And the new lights, yeah. And for playing it on local cable, Channel 26, for those of you who might live locally here, you can watch this anytime you want when you can't sleep at 3 o'clock in the morning. Yes. The Office Bar and Grill here in San Carlos for donating the food that we get to serve to you every week. Sally for constantly bringing dessert. And then, of course, to our supporters whom without we absolutely could not bring this to all of you. A big shout out to Lilly Oncology, Bristol Myers Squibb, Novartis, Genentech, Merck, Astellas, Celgene, Medtronic, AstraZeneca, and Takeda. Thank you, thank you, thank you for allowing us to bring this to all of our beautiful patients. So with that, I'm going to close. Hope to see you guys very, very soon. And let's go grab some cake.
All right.